So the CT scan is a gold standard investigation for paranasal sinus as it provides detailed anatomy and serves the purpose of the operating surgeon. The advantages are it's rapid, it's non-invasive investigation, it helps in documentation, as well as the osteometrial complex anatomy is well seen. The disadvantages are it's expensive, the radiation exposure to the lens, cornea, especially in the axial cuts are quite high. In fact, it is around 185 times than that in a plain X-ray. Now the steps in reading a CT scan, we should always read the CT scan from the first cut. We should read it cut by cut and never jump from one cut to another. That is first, second, third in this way and not one after five. So read the CT scan twice. First, we should always look for the anatomical landmarks. And while we read it for the second time, we should look for the pathology and plan surgery. We should also look for the window setting, the bone window setting to evaluate the bony architecture and the soft tissue window setting to evaluate the disease process. We should never operate without a CT scan. Firstly, because it acts as a roadmap for the operating surgeon. And secondly, these days doctors come within the Consumer Protection Act. So it is an important document in the medical legal issues. So the type of cuts that we need are coronal cuts, axial cuts, and sagittal cuts. Not a single cut is important for actually all the three cuts are important for looking for any structure. So now the things that we need to do prior to the procedure are a brief history of the past surgery. Any old scan should be looked for. The patient should be asked to blow the nose as a simple blob of mucus may be mistaken for a polyp. A short course of antibiotics and nasal decongestants should be given. Now, IV contrast is given just prior to scanning only in few indications where we suspect the tumor to be malignant, any vascular abnormalities, or we are suspicious of any complications of sinusitis. Now, what are the advantages of contrast? It distinguishes between any chronic and active inflammatory disease. Mucosal enhancement is visible in active disease, not in the chronic one. The inflammatory polyps enhance and allergic polyps do not. This is because in inflammation, there is a huge amount of blood going in, and so the contrast enhancement is high. The disadvantages are the non-ionic contrast is actually expensive, and sometimes we may encounter rare anaphylactic reactions. So the non-ionic contrast that we usually use are Omnipec 1 ml per second, a maximum of 80 ml. So the imaging checklist, these are the structures which we should see. So I'll come one by one. So now this is a brief concept of how to know from a cut, which is a bone window cut and which is a soft tissue window cut. There are 2 points. The first one is we can see in the soft tissue window in the right side that the bone is illuminating. Where the bone is illuminating, that is the soft tissue window. And the second point is the soft tissue is better seen in the soft tissue window. For example, all the recti muscles are easily visible in this window. So this is the soft tissue window. Illumination of the bone and the soft tissues being better visualized. Now in the bone window, we can see the bone better with the intervening trabeculae. So this is how we know which is the bone window and which is the soft tissue window. So now coronal cuts. The coronal cuts are from the anterior to posterior view. It is actually in the plane closest to the endoscopic surgeon because we also go from anterior to posterior, and the structures we encountered are similar to that we encounter in the coronal cuts. In the coronal cuts, the osteometrial complex anatomy is very well delineated. Now, the extent of the coronal cuts is from the anterior wall of the frontal sinus to the posterior wall of the sphenoid sinus.